and then of the rest, 37% had an increase and 11 a decrease. So you see a modest impact in terms of moving the patient activation measure. The VR12 is a measure of ability to physical function physically. As you know, there's sort of a major push now to begin to move away from these narrow process measures and begin to ask, well, at the end of the day, did patients' ability to function physically and mentally improve as a result of this intervention? Here, as you see, we had a 3.3% in physical functioning score, a 4.2% in mental health functioning, and then the depression score, which is, this is one of the ways in which people, patients with chronic illness struggle to do the things you ask them to do. They're depressed, and it's hard for them to do anything, let alone the hard things you ask them to do to stay out of trouble. And you see that here we got a pretty good change here. So anyway, think of this as kind of like maybe about a 6th or 7th inning score. At our next meeting, we'll be able to hopefully show you some relevant comparisons. We'll subtract out regression to the mean. But what it does tell me, and I think what I'll use this is to provoke you to provoke the subsequent discussion just for a minute or maybe 5 minutes, Hattie permitting, is that implementing, even when we know, what technically we want to do, and even when we have what we believe is a better way to implement the technical recommendations, we still are a ways away, from being in a situation where we might expect, as a result of that knowledge, we might rapidly move our state out of the third quartile nationally in state health rankings into where I think we all would like it to be. So why don't we just take 5 minutes now, because we started late, but I don't want to finish any later than we started, and I want to invite questions for Mike about his cardiovascular disease specific intervention, or about these early results on an effort to implement a relatively nuanced care model, really focused on pretty significant change in how care is delivered and a subsequent expectation as to how patients would behave in response to that change in care delivery. Yes? A little louder, please.
What risk tool or what risk methodology did you use?
Boy, I wish Lisa was here. I think it's called MARA, MARA? Yeah. Yeah. Yes.
You were mentioning using sortation activation method to lift us from the third to a higher quartile. Do you think there's a reason that California is in the third from a patient activation standpoint?
I want to clarify. California is in the third quartile nationally on the Commonwealth Foundation's aggregate ratings of healthcare system performance and quality compared to all states. That in no way reflects California's standing with respect to the baseline level of patient activation. The Commonwealth Foundation composite includes many different facets of healthcare quality. It's not a reflection purely of patient activation measures.
I guess I was more even asking about the idea that would be the key intervention. And have they done patient activations in other states, or what's the difference between us and other states?
I don't think it's been done a statewide comparison. What we do know so far is that adjusting for all their factors, there is a pretty strong association between level of patient activation and measures such as healthcare spending, meaning the more activated patients are, the lower service utilization, lower healthcare spending. That's been published by Judith Hibbard and her associates from the University of Oregon. How about a question for Mike?
Yeah, Mike, you had some very impressive numbers about specialty engagement around hypertension. Can you give us a little feedback on how you engaged with your specialty doctors and what works to get them to engage around programs like this?
Outstanding question. So the blood pressure engagement is actually part of a bigger program where our specialists will deal with vaccinations, weight management, breast cancer screening, colon cancer screening, a whole bunch of stuff like that. When I first suggested to our specialists they were going to be dealing with breast cancer screening, they kind of laughed me out of the room. It was not pretty. This was a major cultural shift. I think, first of all, is getting some measurement around it so we can actually tell who's doing what and whether people are measuring or not doing what they're supposed to. The other is publicly disclosing the performance. That always drives behavior. We had a small financial award attached to it of probably a couple $100. I think that's more just to grab people's attention. What really helped is we would start to show videos of patient stories of somebody going into a specialty clinic and finding they had bad hypertension or breast cancer or whatever, and we shot the patients. They were great. One of them ended up on TV. You may have seen a breast cancer patient of ours talking about getting screened, but the patient stories are really powerful and make it very hard for folks. And the last thing is get the office staff to do most of the work, and the physician should actually not be spending a lot of time on this. They have to be more of the cheerleader and allowing it to happen. I think those are the main ways we did this.
Great. So, Hattie, we gained 7 minutes in terms of now. Let the next panel come out. Thank you.
So I'd like to ask the people who are on the planning committees or chairing the university best practices and listed on the agenda for university best practices to come on up and join us.